Good morning, everybody, and thank you very much for coming today. I'm really excited to help kick this off, and especially excited to share this stage at the beginning with John Kromm, the Executive Director, HSCRC, and Marie Brand, the Maryland Insurance Commissioner. I think we're going to have a great discussion this morning and then throughout the day. I do, Capper, want to thank you and your staff, as well as all of the sponsors and others for helping put the agenda together and get us started here today. So I'm actually going to not go on further at this point and just ask John and Marie to join me up here. They're really the stars of the show for this first session. So we're going to be talking in this first session around affordability. It's going to be a key part of the day and a lot of the work that you all do, and it will help contribute it. And I want to just do a little bit of framing. Maryland has had a tremendous background and a lot of tools to help with affordability, access, and a lot of the interstitching parts of all of these policy issues. Maryland in 2014 with the new all-payer model converted a lot of what had been historically Maryland's rate-setting approach to really focus on how to advance into the next evolutionary stage of all of it. And it came at a time in 2014 with the all-payer model that the Medicaid expansion was happening, the marketplace and the health benefit exchange was getting started. It evolved over time, became the total cost of care model, and as all of you know, we're now entering a new phase of all of that. We're going to be discussing all of the implications around coverage, access, affordability, and how to build on and learn from some of those past experiences as we really collectively enter a new phase of all of this. Maryland has seen a lot of great success in that period of time. Reducing the rate of growth and costs, improving health outcomes. But as we enter a new phase with all of this, or the ahead model and beyond, there are going to be new challenges, learnings from previous experiences. And as you all know, there are going to have to be some ways of adapting and evolving how that approach takes place. So that's really going to be a lot of the crux of the discussion ahead. I do want to just give I'll do this very briefly, but I did work in the state through a period of time. I worked at the Maryland Department of Health as the Medicaid director in that transition in 2014, and then when the health benefit exchange stood up. And I saw a lot of great leadership across not only policymakers, but all of the stakeholders in this work and in the state that they're represented in this room. And so Maryland has the tools, has the leadership, has the approach to really look into how to best serve consumers, patients, providers, policymakers, and everybody who's a stakeholder in this, the employers and others. So I want to just frame it up that way, and we'll have a discussion here. And I think I want to just turn initially to a broad question to both John and Marie, which is, at this point in time, as Maryland is moving into this new model and taking on some of the challenges coming from the federal policy environment, how in the realm of affordability are you focusing your key priorities in terms of what you're working on that will help signal to all of the key players and stakeholders in the state how to measure success and what success will look like as this evolves. And by that, I mean affordability, whether it's consumers for premiums, out-of-pocket costs, access to care, equity, but also how they're approaching affordability from the perspective of employers, making sure there's adequate financing, the delivery system for security rendered and delivered. And so really, John and Marie, to just start, I wanted just to ask how you're focusing among all of the things that could be done and need to be done, the key indicators of how success will be seen, experienced, and how all of folks here can help support the success that you all are leading on, everybody's participating in. So maybe John and Barik, I'm not sure who wants to jump in, but that's really where I'd like to start the discussion.
All right, I'll start off. So first, thank you to State or Perform, thank you to HMA, thank you to all the sponsors for having this year. This is always such a great collection of minds within Maryland. You know, it's a great environment to have these discussions. Chuck, I think appreciating that question, I think that the first answer is all of those things. All of those things have to move, right, in order for there to be success. I would say from my seat at the HSCRC, I do think at the end of the day, total cost of care is a major precursor, right, to affordability. That's the kind of unique opportunity that we have here in Maryland. So I think that is still going to be a very real key indicator. I'll come back to how that might evolve over time here. But at the end of the day, and I think part of why MIA and HSCRC and other agencies are really collaborating on a much deeper level than we ever have before is because if that total cost of care improvement doesn't pull through to ultimately where the consumer is, the payer, whether it's the employer or the individual purchaser, that then really is at the country, right? There are a lot of steps along the way in between those two things, but I do think coming up that ultimately a little mistake.
Yeah, just to add to that, everything everywhere all at once. Answer AP. The measure that is primarily on my mind right now is coverage and access to here, because I don't think we can even have the rest of these conversations without making sure that we are trying to keep as many people in health coverage as possible. And so we have a couple enormous challenges headed our way. The first one is the implementation of everything that HR1 that our Department of Health and our exchange and I think many folks in this room are working on. How do we be sure that people get to qualify for coverage, get to keep their coverage, because it's not just, community engagement or requirements. It's that eligibility, getting in, making sure that folks know that they have to demonstrate certain things. And there's a lot of really exciting work that's happening in the state of Maryland. But then, the thing that's squarely in my purview that I'm kind of obsessed with is our ACA marketplace, right? I think when we first met, we were talking about our initial expansion of Medicaid, right? And then ACA implementation. And now we're at a place where if the ACA hasn't been repealed, that a lot of the pillars, the federal pillars underneath it have been pulled out or loosened. And so, with the loss of enhanced APTC in Maryland, we were creative. We put in a stopgap state subsidy to help, I think, lessen the blow of losing those advanced subsidies. But I think what we did was buy time. And that time is going to be quickly upon us. And I think this is the year where we're really going to have to think creatively about solutions for coverage and that.
Thank you. Ray, if I can ask one question directly to you now. One of the hallmarks of how Maryland's approached policy uniquely in a country and in a very, very thoughtful and long-term way is to try to avoid a lot of cost shifting across payer types, really respecting Medicare, Medicaid, commercial insurance, and others, not winning by cost shifting, often in other states to employers and commercial payers. And so given some of the coverage loss risks in Maryland, and I've seen figures that are some of the Medicaid-related potential coverage losses coming out of HR1, some of the immigration-related issues, some of the ACA-related issues because of the subsidies, it could put more pressure on the insurance administration and the HSCRC to adhere to really the philosophical point of view that cost shifting isn't the solution, because premium increases could show a lot of employer benefit designs and could show a lot of other things. So as in some ways we move backwards from the ACA era and the time where you and I worked together more closely, how is the insurance administration approaching maintaining affordability, not enabling cost shifting, and keeping for employers and other groups premiums at the best possible place, recognize that ultimately the providers to have significant financing to provide care? How are you approaching that given the shift in coverage mix and payer mix and in your role at all of that?
Yeah, that's a great question. So I think the first thing of course, we do at the MIA is review, right? We look really closely at our ACA brackets and rates. We want to make sure that hospital growth is appropriately a big accountant for. Make especially sure that any increases line rail with what the HSCRC is approving. But I think the other big thing that we do, and I think John mentioned partnership, right, is the importance of state agencies talking, is really being transparent about what we are seeing in the market and making sure that our other agencies understand that. And I think especially in this time of decreasing resources where we have to be creative and innovative, we also have to partner. We also have to look at the whole health system collectively and understand that cost shift in one place will have ramifications in other places. When I talk to other insurance commissioners, everyone in the country is concerned about healthcare affordability right now. Like, it's a universal concern. But the other thing I hear is, at least at Maryland, you have tools to help address some of the cost draggers and growth, and I think we just have such a rich history of that. We're going to have to be very careful and thoughtful about the next forward, because healthcare coverage is the economy too, right? Like these are I brought a piece of paper because I didn't want to forget, but the average clear cost of coverage for a family in Maryland as of 2024, according to MAPS, was $24,738 for the average employee contribution to that was over $6,000. So our employees are paying it, but our employers are paying it as well. So that's why it's just so important to continue to talk and partner as we enter into this new phase of hostilities.
John, one of the questions I wanted to put to you is Maryland has a long experience of learning from different models, and as the state moved away from the long-term historic all-payer rate setting model into the 2014 contractual arrangement with CMS, and that beyond that total cost of care, how much of a head, what lessons can you carry forward into this new era, and what needs to change and evolve in this year? And I think this is a group of folks in the room who are largely, I think, probably aware of some of the improvements with primary care, of how there's going to be a transition over time to not only focus on Medicare, but Medicaid and commercial, and really kind of all payer in a much truer sense, total cost of care in a much broader payer sense. But what lessons can you carry forward and learnings from the past, and what do you want folks to be aware of needs to evolve in this new period of time going on?
Yeah, so I think you touched on a couple of the main lessons that we should keep in mind, and then as other states are going down this path as well, they should keep keeping in mind as well. One is the all-payer component of this, which will change under the ahead model, mechanically how that works. But that's just an incredibly important kind of construct, right? The alignment across payers is a true advantage, I think, and it's popped by 1,000 different ways, from drug readmissions down, the additive, multiplicative effect you get by having that, having a hospital working on that from an all-payer perspective is cannot be understated. I think also we ought to look at what has been the main driver of affordability action within the model of those years, and it's really been, quite frankly, it's been inside of service shifts, right? So ensuring that patients get the right care at the right time in the right place, that has been a major advantage within the model over the last decade. That has to be preserved and maintained. But I think as we move forward, we can also learn some lessons about how to do functionally more coordinated population health management across payers, across settings, and providers. I think that's really where a lot of the advancement is going to come under the HEB model, and it looks kind of different depending on which aspect of the problem that we're trying to tackle. Could mean more work in the community, but it could also quite simply be more coordination across acute care, post-acute, right? That's where a lot of the innovations are going to have to occur over the next decade. And then the last thing I would mention is, I think one of the places in which we have to evolve our thinking is most everything that we've done has been looked at state, right? So the site of service shift, that action at a statewide level has been a huge advantage for affordability in the state. But then when you drill down and on the regionally, right, we've hit thresholds, appropriate thresholds, in some parts of the state. We haven't in others, right? So how do we get more nuanced about kind of regional approaches to alignment and kind of optimizing healthcare delivery, et cetera? I think that's another place where we could both learn from lessons in the past, but we'll need to evolve our thinking and become more nuanced as we go.
So for folks in the room, as everybody kind of watches this progress, what are the indicators of success that you hope they see? And I will actually just ask the follow-up to this too. So for consumers, for employers, for the state policymakers, for the provider community, how will they be able to observe success in the ways you would hope it would roll out, for both of you? And related to that, what do you need from the stakeholders in the state to help support the work you all, the Maryland Department of Health, MHBE, MHCC, and others are working to achieve? So how should people pay attention to what to expect when in terms of success? And honestly, what do you need from everybody to help this be successful?
Well, maybe I'll start. So I think the first thing we need from everyone, which I think we have a great history of in Maryland, is your partnership, right? This is such a critical time. We need your info, can need your partnership. I think I think everyone in this room knows too, we are dealing with a shortage of resources. So we also need your creativity. And if we can, if it's just a sort of like everyone tries to grab, think of the piece. I'm not saying that's what's happening. But if that is what happens, none of this is baked over, and it's not going to work well for years. But I have great confidence, just give it on theory, give it on partners, that will be successful there. I think with healthcare, also been talking about affordability for a long time. I think sort of the total affordability may have left the building, but I think we need to make sure that we are bending the cost curve for all payers, not just that payer, just but for our individual businesses going forward. And we have tools to do that with ahead, right? We have our total, all payer total cost of care target. And then we also have tools to make sure folks are getting care earlier and in the right setting with our primary care investment and programs, and our target there. So I think, success to me looks like we are not experiencing coverage losses, maybe even experiencing coverage gains down the road because we still have a stubborn uninsured rate here in the state. But that also people are able to access care when they need it in the right setting.
Yeah, we completely agree with that. I think from a measurement perspective, we are moving to a place where we'll have more granularity about what are the drivers of cost and on an all-payer basis within the state. That's going to be really important. So we'll be able to look kind of at line items on that spreadsheet in a different way than we have in the past. So we'll have new, essentially key performance indicators about how the healthcare delivery system is performing from a cost basis. But ultimately, I think the real indicator is exactly what Marie said. If Marylanders feel less friction in their lives, that will be success. And success can't be counted until they feel that, right? And that is both less friction because they're not being forced to make difficult decisions about what they can afford, and not so challenged in terms of accessing the care where they need it and where they need it. So I think ultimately that's got to be measuring stick. Will that happen tonight? Absolutely not. And so I think speaking to your engagement, the engagement part of your question, I think we do need engagement from all corners of the state, including consumers, including individual purchasers of coverage and healthcare. And we also need kind of recognition that a hospital rate setting is a unique thing within Maryland, but it is but one tool in the toolbox. And so I think we need our stakeholders to think about some of the venues that we create for engagement as, hey, we need multiple perspectives, the creativity to brave all of the tools that we have in the toolbox. Not just hospital rates, not just the ad law, but thinking about our coverage programs, thinking about some of the state social services programs that we have. How are we leveraging those things in more holistic and comprehensively across the state? I think increasing the CPOC from the agencies and hopefully from other leadership within the state as well, more holistic things for providing feedback and to the state.
I want to ask a question that comes out of a recent federal final rule about the ACA, where, among other things, the federal government had released a final rule for 2027 marketplace-based plans. And one of the elements of what CMS just released is expanding what they're referring to as like catastrophic coverage, which I'll do a little bit of preface, but then I'll really get to the question, and it's not just the ACA. So for younger people, there was a way to buy like a skinnier version of coverage through the ACA to try to keep premiums down for generally healthier younger people who are getting access through the ACA. That catastrophic option has been expanded and made easier to try to have lower premiums for people even who are not quite as young, over age 30, can follow by your science. The implications of that is there's a lot more risk about is having maybe an affordable premium, but a lot more risk around out-of-pocket and a lot more risk if there's conditions that require accessing services with a very high deductible, a lot of out-of-pocket. And so that's kind of an aspect of what may happen in the ACA is more take-up of the catastrophic version. But on the commercial side, and Marie, part of this is as your administration looks at, for the employers that are subject to your review, how you're thinking about and how you intend to evaluate plan designs that might be doing more cost shifting to employees as a way of trying to maintain affordability for employers and keep people employed and manage to their own financial strength. So one of the implications that's happening right now is a cost shift of different, not a cost shift between Medicare, Medicaid, and commercial at the macro level, but a cost shift to consumers, employees, and other people who utilize care at the point of care. And I'm wondering how you're thinking about plan design and how MIA is going to think about evaluating that aspect of affordability and access.
Yeah, that's a great question. I think it's a dynamic that unfortunately has been going on for a long time, where and let me just start by saying I think folks know and our ECE markets, there's a lot of rules around plan design. There's a bucket of actuarial value, right? So unfortunately, to get to those, sometimes plans do have big deductibles or do have big cost sharing, or they do have big co-payments. And I think working with the exchange and working with folks in this room, the one way Ireland has addressed that is by presenting value plans, right? So through plan certification on our exchange, we don't necessarily have standard plans like what the federal government had, but we have something called value plans, which it takes a level at a lot of those issues. That's very helpful. I think the risk of, in an era of growing healthcare costs, if we don't have a check on it, there will continue to be the temptation of employers to, instead of raising premiums, to raise cost sharing. I think we're seeing that, and we've seen it over the past 10 years. And unfortunately, that fits it hits consumers in a couple ways, and it also gets our provider community when if folks don't have an HSA that's full of paying those kinds of deductibles, then they sometimes providers have to chase in those situations. So I think those are all of the dynamics we're looking at, but I guess I would also flip it back and just say that, if we don't get serious about bending that cost curve, we're gonna see more and more of those dynamics because, there's just nowhere for that money to go. I think sometimes folks think of the insurance companies as, well, they can just eat it, but they don't. Insurance companies are administering a benefit on behalf of individuals and employers. So while there may be things that we can do in terms of insurance regulation and making sure payers are accountable, at the end of the day, the folks paying their costs are individuals, not employers.
Yeah, just to offer a hyper nerdy way of looking at that call. one of the things that Maryland has historically been able to have is a really thoughtful and balanced spread of risk throughout the value chain of healthcare delivery. I think one of the concerns is, does that get out of whack? Does that get pulled out of shape over time? So if you think about historically the products that are available in the insurance products that are available in the market in Maryland, all the way through to, let's say, the uncompensated care fall, right? That's a balancing act of risk, right? You start to focus your risk on one end of this, without usually, it has cascading cost challenges throughout the entire system, right? Because it's an inappropriate level of risk to bear at one part of the one link in the chain. So I do think both as our federal partners think about policy, as our stakeholders think about how they're organizing their businesses and organizing their work, and then other states too. One of the views that we have to have here in terms of affordability is, are we achieving affordability in a risk appropriate way, or are we getting there in a way that's going to come back by us in a couple of years down the road?
Yeah, just one observation, and then I have one more question, and then I do want to make time available for all of you. I might want to ask some questions as well. We've seen in a lot of contracts nationally tremendous backlash against the insurance companies for being over aggressive with utilization management, prior authorization, denials of care. I know that there's been concern on the provider community in Maryland, and not just in Maryland, about the affordability being addressed through pretty aggressive insurance company practices. And it, to try to be balanced about this, if the insurance companies still feel like they have adequate premiums, and yet they're supposed to work here, it puts a lot of stress on, what is medically necessary, what's appropriate care, was there overcoding, was the wrong site of service, etc. But the denials and utilization management approaches, the prior authorization approaches, is a blunt instrument to try to get to affordability, which also can't be the only solution or even over leveraged as a solution. I'm not sure that that's something that you all are thinking about too. Let me just tee up for your responses and reactions. I see, Marie, you might have something to say about this.
20 minutes.
But my question will be, or is, are there policy tools that you still need that you want to maybe mention here, and for those of you in the room who can help support positive, effective, necessary policy changes to help get to the solutions all of us, all of you want? I want to give John and Marie you the opportunity both to mention really the policy changes that I think would help you get to the good solutions here. But on the insurance behavior part, Marie, if you want.
Yeah, so first of all, I think, Chuck, you said it exactly right, where I think prior auth utilization management writ large is many types of program, right? There's waste in the system. I think it's an appropriate role for payers to conduct utilization management. But I think what we've seen as healthcare costs grow, employers are demanding employers, and not just employers, purchasers, right? Our Medi program, right? Is purchasers are sort of demanding from insurers or cost containment a clumsy, easy way to do that. It's prior auth and utilization management. Not like that. Graduate that up. In Maryland, we do public recording for our fully insured commercial market. We saw since 2015 prior adverse decisions, which can be it's a denial based on medical necessity. As that market shrunk, adverse decisions doubled. And most of that was driven by pharmacy. I think you've seen a lot of cost growth here in Maryland. So we are doing a lot of work on that, actually, probably with a lot of folks in this room. We have a work group meeting on adverse decisions. I think there's a desire from many of our providers to have a more uniform approach, because I will say the market that I regulate, that fully insured commercial market, has the most restrictions on free utilization of any market here in the state. But I think there's a desire to get to a more uniform space where there's a more common understanding of what is going to be subject to prior auth, where the decisions move more quickly. And there's just a lot more transparency so that we are, I suppose, appropriately managing care, making sure there's not fraud, waste, and abuse, but at the same time, we're not just throwing sand into the system, because I think that is deeply upsetting and frankly costly for both providers.
I would just say, prior auth, adverse decisions about the symptoms, right? And so if we think about what are the things that we externally, right, for the externality that would be alcohol, right, is some management of underlying unit cost of things like drugs, right, would be great. But internally, you're the state, whether it's through regulation or the market is creating these solutions. More value-based care, right? More value-based payment helps us get to a place where there's less reliance on those types of tools, which are a great set black instrument, and now always accrued to the needs of the patient.
Your policy hopes for things that make you tools that you lack from a policy perspective that would be helpful to get to success, and then hopefully we'll have time for one or two questions from the audience.
Well, I think just doubling down on what I just said, I think flexibility to build value-based payment across payers and across settings is key, right? Where that flexibility comes, whether that's from federal partners, whether that's us at the state level, whether that's braiding authorities across our agencies, I think that is where a lot of the policy development is.
You may just, I'll mention something maybe not specific to adverse decisions, but I think we've touched on, but not said more explicitly, is I think to do all of this work in an era of shrinking resources, population health investment, rating, that working across the agencies, it's done even more critical.
Thank you both. Questions from anybody? And I see Heather in the middle of the room with a microphone.
Good morning, Jill DeBrass with Be Well Connected Health, a Maryland founding company. One item that I didn't hear in this conversation had to do with interoperability, because we do have fundamentally a cost curve problem. I got into this business shifting from technology because 15 or more years ago, we had 17% of GDP devoted to healthcare expenditures. We haven't changed the cost curve. And if we don't actually keep that metric front and center, we're not going to do anything. And interoperability through the federal mandates is actually creating a forcing function for us to think differently, not just from a policy perspective, but as builders and operators, to actually synthesize data, unify it on modern standards, so that we can actually do good things with that and drive to use cases that actually hit those objectives.
Yeah, no, Matt, I mean, so we're fortunate in the state to have Chris as a really good partner in achieving some of the things that you're talking about, right? The reason why I mentioned Chris is because I think interoperability is really important, but how interoperability is leveraged on a kind of statewide basis, right, to do population health is really, really critical. If interoperability is just to manage one transaction or one episode or what, then like that's great. That's additive to what we have sometimes today. But where the real strength comes in is when we can use that almost as a utility, right, across the state to do statewide population health management.
I'll just encourage a bunch of folks to come to the AI conference or breakout, because we'll talk about that in more detail, because it's absolutely critical to have CRISP as a partner, but all of us play an important role in trying to modernize our stacks so that we can actually transact data across in an efficient manner. And I'll also say consumers are critical stakeholders in all that, because guess what? We know where fraud is when we see it. So we need to get the data liberated for consumers too.
I think we have time for one more question. Going once, going twice.
Okay, thank you all very much. Let me please ask you to join me in thanking Marie and John.